I would request Professor Dr. Ramachandran to again enlighten us on the Sustainable Development Goals as she was speaking. And ma'am, please.
It is the audience who gives the inspiration, and therefore I would rather stand and talk seeing all your faces. Okay, today what I am going to talk about is not Bihar, but about India as a whole. Millennium Development Goals 2015, India's achievements, the current concerns and constraints. What are Millennium Development Goals? At the Millennium Summit of world leaders in the history adapted what they called a path-breaking declaration to improve health, nutrition and quality of life of all the citizens in the new millennium. This was called as UN Millennium Declaration, and it committed all the nations in the world for a new global partnership to achieve basic human rights to food, health, education and improved quality of life. UN adapted 8 Millennium Development Goals with 21 targets and 60 indicators to be achieved by 2015. The base year for this was taken as 1990, that is a decade before the millennium. So they looked at past performance between 1990 and 2000 and hoped for an accelerated performance between 2000 and 2015 and gave some goals. What are the Millennium Development Goals? Eradicate extreme hunger and poverty. Really not health, but the hunger index that they chose was not hunger as you and I know, but undernutrition in people, and therefore one of the primary pillars of primary health care is nutritional status. So subsumed in it is health. Achieve universal primary education, an enabling tool for all health programs. Promote gender equity, empower women, yet again another empowering provision for improving maternal and child health. Reduction in child mortality squarely on health front. Improve maternal mortality and improve maternal health. Great, that's what obstetricians dream about. Combat HIV/AIDS, malaria and other major infectious disease. Special mention was there for tuberculosis. Goal 7 was ensure environmental sustainability and develop global partnership for development. Not very closely related, but still without it we cannot improve holistically the health status. India is a signatory to the Millennium Declarations and is committed to strive to achieve MDG by 2015. As I said earlier, 4 out of the 8 goals pertain to health and nutrition, and these are the indicators used and targets set for reduction in the 4 goals pertaining to nutrition and health between 1990 and 2015. Goal 1, eradicate extreme hunger and poverty. These targets are 50% reduction in people with income less than $1 per day and 50% reduction in hungry persons as assessed by prevalence of undernutrition, especially in under 5 children. This is a thing with which I will take some time to explain that really undernutrition in under 5 children in the Indian context is really not an index of hunger, food insecurity or poverty. There are other reasons for it, and that is the reason why continuously India is told you are not performing very well in relation to nutrition. Reduction in child mortality, always a major input in all planning. 2/3 reduction in under 5 mortality. Improvement in maternal health, 3/4 reduction in maternal mortality, and of course combat HIV/AIDS, malaria and other diseases. The target given is halt the increase in by 2015 and thereafter reverse the incidence of HIV infection, tuberculosis and malaria. Ambitious targets, but not unachievable targets. Let's now look at each one of them one by one. Target number 1, luckily for us, this is one target which the world and India have achieved. This target is to achieve a 50% reduction in people with income less than $1. In spite of the ups and downs, globally, there has been a reduction overall to more than 50%, even in developing countries. And I want you to have a look at this. If you look at developing countries, the poverty reduction in them is much more significant. This is what we want things to happen. This is inequality reduction between developed and developing countries, and therefore we need to congratulate the world for having taken steps in the right direction. In India too, the number of poor did a steep dive, especially after the 2003-04 period, and India has also achieved reduction in poverty ratio ahead of time, right by 2012. A thing with which we feel good and then say, we can do things. But we also have to look at it. Complicated diagram, don't look at it. I'm only showing you, this is one of the methods by which you can depict 30 states without clutter, giving 3 lines: current status, likely achievement and target. Without having 60 lines which nobody can read. It takes time to understand, but not to worry. We have extreme levels of poverty, we have low levels of poverty, some achieving goals, some not achieving goals. So there is a huge disparity between different Indian states, and the disparity within India is literally a mirror of what we see between countries in the world. Then we come to the real crux, reduction in undernutrition, and this is where India is seriously in trouble. When I mean seriously, I really mean seriously. Please look at that. The world is going down in terms of undernutrition reduction, 23 to 12.9. ठीक है, लगभग 50% कम हो गई. But will you please have a look at Southern Asia? We are not very poor countries. We are not conflict-ridden countries. We do not have a poor governance. India, in fact, is one of the countries today, if you believe the news, we are global number 1 economy in terms of GDP growth. And where are we? The highest under 5 undernutrition rates. Reduction has been from 50 to 28, really, really suboptimal. We fare worse than rest of the world. Why? Why is this happening? Let's look at Indian data now. Luckily for us, we have the National Nutrition Monitoring Bureau and National Family Health Survey, which go back to decades and tell us what is happening to undernutrition in under 5 children. There has been a slow but steady decline in undernutrition as assessed by stunting and underweight, but practically no change in terms of wasting. While all concern has been expressed about underweight children, hey Bhagavan, kya ho raha hai? Practically nobody talks about wasting. And this is one of the tragedies that India has. As I said, really, you do have a huge variation among states. Madhya Pradesh, Bihar, over 50% undernourished children. To other end, small states in the northeast, Kerala, Goa, Punjab, which have undernutrition rates which are less than 20%. So here again, states of India reflect various states of the world. But when we compare us as a nation with rest of India, there is no escape from this. Take stunting, we are worst off. Sometimes it looks more worst off than sub-Saharan Africa. Take underweight, Ditto, we are totally brown. Sub-Saharan Africa is not that badly brown. And lo and behold, wasting. Really the Sub-Saharan Africa, most part is not that bad, but India is uniformly red. Why? And this is the reason why again and again we are shown India cannot perform. India cannot upscale. India is really doing very, very poorly in terms of nutrition and in terms of development. But if you ask us nutritionists, we will say stature of Indian child is not a good indicator of food security of the household or of the child, and therefore we should not be using this as an indicator to assess food security. You want to talk to us about nutritional status, wo alag baat hai. But do not say we are doing insufficient things for nutrition. And why am I saying this? Please have a look at this. These are Indians, National Family Health Survey, stunting rates, underweight rates, wasting rates in 3 income groups. The highest income tertile, that is the top third, are all of us families which have not known economic constraints for eating for 3 or more generations. Want to look? You look at some of us who are in our 60s, our statures are quite good. Okay? So that's the reality too. I certainly belong to that generation. You can't fault me in terms of nutritional status. And even if you look at this kind of families, 25% of children are stunted, over 20% are underweight, 10% are wasted. So, where did our food insecurity come from? And it's not lack of health care, because we certainly accessed health care. You look at our immunization record, you look at the way we are accessing everything and are performing. Okay. If I am challenging something, I ought to also be able to say, what are the factors that lead to this so-called high prevalence of undernutrition in India? One of the major factors here is low birth weight. You all know about a third of Indian infants weigh less than 2.5 kg at birth. We all know birth length and birth weight are the single major determinant of growth, not only in infancy and early childhood, but also in adolescence, so therefore adult stature. And here is the National Family Health Survey. Just on that criteria, less than 2.5, more than 2.5, stunting rates, wasting rates and underweight rates. Very significantly different, and therefore unless we do something about birth weight, which is not at all easy, you will continue to have, compared to global standards, high stunting, underweight and wasting rates. The second major hassle that we have is infant feeding practice. In India, breastfeeding is universal. 100 marks for perceptive Indians. We didn't go through the hassle of switching over, creating complications for everybody, increasing mortality, increasing morbidity, increasing undernutrition rate in under ones by following the Western norms of bottle feeding is the best. Ever. India never went through that. But what are we doing wrong? You see, the so-called exclusive breastfeeding, even at 6 months, is pretty low. Upar ka doodh is one of the terrible things that happen between 3 and 4 months in majority of households. We have another problem. All of us may do annaprashan at 6 months, but thereafter what? Not even 10% get adequate semi-solid complementary food. And without that, there is inadequate calories in the richest of the rich households. Yet another thing, अरे कौन बार बार बनाएंगे बच्चे को, वो खाता ही नहीं, 2 स्पून खाने के बाद सारा फेंकता है. किसके पास इतना वक्त है? The result is giving adult food, practically not. But what you need, nutrition education. mash the wretched chapati and rice in little bit of anything that you care. Milk, sugar, good, thoda se pani, feed the child. What is hampering you? We are unable to communicate it, and that is one major reason. You can see how severe it is. In the first 3 months, almost all children are breastfed exclusively, and there is no increase in underweight rate. 3 to 5, upar ka doodh has started doing its misery, so undernutrition rate goes by 5%. Delay in introduction of complementary food, inadequate complementary food. By 11 months, almost 50% of the children are underweight. This is not related to food security of the household. This needs nutrition education for correction. What do we do for nutrition education? Do we have to have breastfeeding counselors? Every house shall have a trained nutrition counselor. आप कहाँ रहते हैं? Certainly not in India. But do we have a tool which will do it for you? This is the Mother-Child Protection Card brought about as a joint effort of Department of Health and Department of Women and Child Development 7.5 years ago. Some of us have worked on this joint card, believe me, 6 years to get consensus. ये नहीं होना है, नहीं ये गलत है, इसको include करना है. And unless you build consensus in this country, you cannot move forward. And therefore, it took us 5 years to finalize it. Though some states have introduced cards earlier. Gujarat, for instance, had a Mamta card. Tamil Nadu always had its own card. But this explicit card that goes across, talking about infant feeding in this clear terms, came 6 years, 7 years ago. Many doctors do not know about it. Across the system, nobody uses it. And where is its greatest use? Whenever we all give a message together, that message goes through. There are, every time our AIIMS, our Anganwadi workers, our young doctors talk to a family about infant feeding practices, the mother-in-law or the mother who were brought up with the knowledge, which was correct at that time, inherited from Nelson's Pediatrics, at 6 weeks, unless we give additional feeds, Indian children cannot catch up. With whom? Where? Horizontal catch up? Do you want fat children? Do you want to give prizes to people who are going to become victims of obesity just 20 years down the line? So how do you counter? आपका क्या मालूम है? आप तो छोटी है. Dismissal is routine in the community. That is where this helps. Every doctor should use it. Tertiary care, quaternary care to Anganwadi worker, and if you access this, authentication is provided by the Government of India and DWC. This is what everybody believes, and this is what all of us up the line and down the line will tell. Please use it. You will see a huge change, because conflict of opinion is what is coming in the way of effective implementation. As I said earlier, morbidity is inevitable in our environment. 10% morbidity is to be accepted. It goes up to around 20% in the period when you are introducing additional food, complementary feed, shift over to adult food. And that high rates will continue until 3 years of age, when the child is really on to adult solid food. And morbidity is associated with reduction in body weight. I would like you to have a look at this data from National Nutrition Monitoring Bureau. In 1975 to 80, nearly 80% of the children were stunted, under 5 children were stunted and underweight. And by mid-90s, this has come down very substantially. What was the input that happened? What happened was primary health care. Urban and rural primary health care got going. People started accessing, because the other process was ICDS. But ICDS never had very good coverage at that time point. What can health do to nutrition? Do you need any further evidence than this? So, please, please, never give up the fact that health is a major contributor for improving nutritional status in children. Would like to next again show you the same slide. Stunting and underweight in India worse than sub-Saharan Africa. But would repeat, this is not due to household food insecurity. Low birth weight and stunting and underweight in India are not associated with adverse health consequences such as very high morbidity and certainly not very high mortality. Reduction in stunting and underweight are happening, will continue to happen, perhaps accelerate a little bit, but it will not be a rapid process. 50% reduction in 5 years, forget it. It's not going to be achieved. Setting unrealistic targets will really get the people disbelieve you. On the other hand, look at wasting rates. 1 in 6 Indian children, this is believable. Alternate child undernourished doesn't even really sit well with our common sense. 1 in 6 child, yes, that is our poverty line. 20% are below poverty line. 16% of children are wasted. TK. And to 1 in 6 to give an additional health care, an additional food, certainly doable. There is no hassle there at all. And remember one thing, wasting is reversible very, very fast. In 3 months' time, a wasted child can be brought to normal nutrition. Because feed, treat infection, the child will recover. And this is a fast. And what will it do? It will make the child grow according to its trajectory. So no further stunting, which is a major prevention effort. So that, and is that all? No. If you do that for adults, it will improve their work capacity and earning. And if you do it to women, it will improve low birth weight. What more do you want? Can't you take height and weight? Can't you calculate BMI using your mobile phone? Why are we not doing it? I still don't understand, but will you try doing it and see what happens? So therefore, I would plead with you, in India, stunting and underweight rate is high. Underweight rate is high because stunting is high. Reversal of stunting after first 2 years is a sheer impossibility. Many short children today have high BMI and they are overnourished. They should not be called as underweight. India has entered the dual nutrition burden era. If you shift over to that single thing, take height, take weight, calculate BMI. I know we are all mathematically challenged, otherwise we wouldn't have come to medicine. But we don't have to worry. There is a mobile phone in everybody's hand. Calculator is a part of it. Calculate and put it over, plot it over the chart. You know where the child is. Now give the right advice. Kya problem hai isme? Kuch bhi nahi. Start making the effort, you will see the difference. The other major thing which is thrown at us, food supplements. India has the largest food supplementation progress. Lekin kahan hai uska impact? But impact milna hai to you should target. You don't treat malaria by giving half chloroquine to the entire Patna population. You take smears, you identify the person and give them the full course. Here, the program covers the entire country. ICDS is one of the most widely entrenched programs, but basically it went through the social welfare mode. In the beginning in 1970, when 70% of Indians were poor and 70 to 80% of children were undernourished, koi bhi hai, idhar la do, kuch khana khilayenge. That was the logic. But in 2015, that can no longer be the logic. The number of people who are receiving supplements continuously is very, very low. Food supplements often act as a substitute for home food or is shared with others. I will not say anything against sharing because this is what keeps the family going in India. If there is little, share it with everybody. And that is the generosity which we should teach our children. But it does have an impact in terms of who is getting the food. We don't identify undernourished children, do not give them rations, and do not monitor weight. The nutrition focus is the weakest link in ICDS. As I said, nutrition education is poor quality. What do you need? Mother-child card. It's the birthright of every child. Please give it. Weighing is critical. क्या प्रॉब्लम है? बहुत अच्छा बैलेंसेस है. तोलना शुरू करो. Correct, detect and correct growth faltering. Early detection of undernutrition and manage. So really, if we just correct small problems in ICDS, it will click. Ensure nutrition education using mother-child card. Ensure weighing to detect growth faltering. Identify undernourished children. Provide them with double ration. It's there as a part of the program. Provisions are made. कहाँ जा रही है, किसको दे रही है, घर में उसको क्या कर रही है, ये तीनों में प्रॉब्लम है. इसको सही करो, बिल्कुल ठीक हो जाएगी. And please check them for infection during the Village Health and Nutrition Day and monitor improvement in nutritional status. The other program is midday meal. It was meant as a school enrollment program, but since it didn't start looking at school hunger, Supreme Court directed that hot cooked meal will be provided, and today that is reaching over 100 crore children. But 100 crore children, who? Can it not look at nutrition? It's an opportunity to improve nutritional status. We can take height and weight, it's part of school health. We are not doing it, but we can do it. Identify undernourished children, get them checked by the school health system, provide them with double helping of MDM. Undernutrition will be a thing of past. Identify overnourished children. This is the time, not when they are 20 and have a BMI of 30. Make them run around. You have not only sorted the problem when they are young, you have set a lifetime habit. This, you please show this to any grandmother. She will tell you, these are normal children, उनको कुछ नहीं करना है. Height and weight are irrelevant. They have normal body build. And the second, it doesn't matter height or weight. All these children are thin. दुबले पतले बच्चे को थोड़ा एक्स्ट्रा खाना देना है. Why can't we understand what the grandmothers understood? And this is equally clear. Forget height and weight. Those children who are fat for their current age and height should be told to run around. No reduction in dietary intake, but run until you become normal. Common sense, can do, but will we do it? I'm sure when we make up our mind, we will certainly do. Sorry I took a little longer, but that I think is the crux where we ought to move, and that's why I devoted more time to it. We now move on to child mortality reduction. This is very well known. The target was 2/3 reduction. In this, thank God, South Asia comes way low, Sub-Saharan Africa on the top. We all know that neonatal is the major contributor, and the first day makes the huge difference. With improvement in institutional delivery, we will be doing somewhat well. Both globally and in India, reduction has been substantial, beyond 50%, but we haven't been able to achieve 2/3. We can do if we strive hard. I want you to please look at this slide. This is under 5 mortality in 1990 and under 5 mortality in 2015. If you look at this, we are nowhere near Sub-Saharan Africa. We are along with all our neighbors. Kushal Mangal, not Kushal Mangal, but we are along the same. And this relatively low infant and under 5 mortality, in spite of high low birth weight and undernutrition in under 5 children, has been called a South Asian enigma. I do not believe it's an enigma, and I want you to see these slides. It also shows what India can do in clinical research. In 1960s, 40% of Indian infants were under low birth weight. Dr. Shanti Ghosh, a very eminent pediatrician, a guru for many of us, undertook a very elegant clinical study of neonatal survival in Safdarjung Hospital. She showed that mortality rates were higher only in those who were born before 37 weeks or weighed below 2 kg. Neonates needing intensive care formed only 12%. Luckily, in those days, all pediatricians stood together, regional data came, and Government of India accepted these recommendations and organized intensive care nurseries for 12% of hospital births. Doable. If we had said 40%, they would have said, chalo, dekha jayega agle 50 saal mein. But when you said 10 to 12%, immediate action. Result, good reduction in neonatal mortality, hospital-based. Slowly referral system took care of the rural also. As I said earlier, universal breastfeeding and improved access to health care also helped so that not only neonatal but infant mortality in India fell. India pleaded. Many of us have gone to world fora and said, please let us use our own birth weight, gestational age, related mortality for not anything else. We will report low birth weight to you, don't worry. But for us, intensive care, we will use our cutoff. No, can't be done. How can you have different standards? Never ever accepted. And now what is happening? Currently, many developed countries, the preterm births weigh over 2.5 kg. So they have a problem. In spite of 2.5 kg, they have a higher mortality risk. Their preterm birth rates are growing up because increasing interventional obstetrics, okay, it exists. And so now they are demanding risk of mortality in relation to birth weight has to be documented and used as criteria for providing intensive care. Why? Otherwise, so many insurance companies are refusing to pay parents with real at-risk children. So the plea now comes from Canada, UK, Sweden, Norway, Denmark, take any of those picks. India's stand that admission to intensive care nurseries should be based on national data is now vindicated. How many decades later? 5 decades later. Doesn't matter, never too late. We had between 1990 and this achieved significant reduction in both rural and reduction of rural and urban infant mortality, and the urban-rural gap is slowly but steadily narrowing. That's good. Though we will not be achieving 67% reduction in under 5 mortality, we are pretty close, 48 to 42. Institutional delivery, then there is a Shishu Shiksha Abhiyan. If we really give a push, that should not be creating any problem there at all. There is, however, no recognition for this major achievement. Everybody keeps on talking. High undernutrition rate is a national shame, and India should be ranked way low. Despite this, we achieve a significant reduction in low IMR and low under 5 MR. Where is the statement? अच्छा इतना अच्छी तरह आप काम कर रही हो, हम आके आपसे सीखना पड़ेगी. But there is every reason to say this is a national achievement. If we are going to say that's a national shame. So it all depends on how you look at things. We'll now move on to reduction in maternal mortality. Again, South Asia fares reasonably well. There has been a substantial reduction, but neither in the globe nor in India will 3/4 reduction in maternal mortality achieved. That's because I believe it's a too ambitious goal. If we had said 2/3, perhaps we could have come near achieving it. In India too, there has been a maternal mortality reduction which is reasonable, but we are falling short not only in maternal mortality reduction but the second goal, which is universal access to skilled birth attendant at delivery. 70-80%. Somehow in the last 2-3 years, that has stagnated. We need to push it up. What happened here, if that trend has continued, you can very clearly see we could have achieved. Complacency should not ever be allowed. Finally, I come to HIV, AIDS, malaria and tuberculosis. HIV came to India and to the world in mid-80s. Globally, there has been a reduction in the incidence, and incidence rate, antiretroviral treatment rate, death rate have all significantly changed over time. In India, we have the distinction that care of people with HIV happened within the national program built on the basis of ICMR serosurveillance data and without any adverse impact on health care for any other disease. India's low-cost generic ART prolonged the life of lakhs of Indians. Of course, if we manufacture drug, we will give it to others. Not only in India, it saved many more lives in Africa. Is that all? No, we also exported it to USA, and the poor in USA benefited from our generic drugs. Does anybody say, oh, India did something great? We have good prevalence in reduction of HIV, near elimination of bloodborne and mother-to-child transmission, and AIDS epidemic has no adverse impact either on mortality of adults, infant and young child mortality, or undernutrition rates. Nothing. With or without AIDS, no difference. Did anybody say, what a great India, we should all learn from it? No, nobody. But do we need anybody to say, we know our strengths and we shall always feel good? When new epidemic hit India, we know how to take care. Our problem is old things which are there and we are not able to tackle it. We now move on to malaria. Globally, there has been an increase in mosquito net use and also reduction in incidence, especially noticeable in Africa. And in India, yes, malaria cases are going down, but please note, falciparum incidence is going up and up and up unrelentingly, and perhaps because of this, despite reduction in number of cases, reported deaths due to malaria are not going down. This is a warning. We should take care. What has been happening to tuberculosis? There has been global reduction in incidence and tuberculosis related mortality. India reflects the same, but here again the note of caution, multidrug resistance and extreme multidrug resistance pose their own challenges. We need not become complacent with the so-called performance. To sum up, if we look at the globe, the first goal is achieved, 50% reduction in poverty. But child undernutrition, even the world didn't achieve it. 3/4 reduction in MMR, no, off target. Universal access to attendance, no, off target. This we should have achieved. Mortality reduction is more difficult, but universal access we should have done. 2/3 reduction in under 5 mortality, no, not achieved. Vaccines, really not achieved. We should have achieved universal coverage globally. Halt and reverse incidence of HIV, malaria, TB. ART treatment has gone up leaps and bounds. Insecticide treatment has gone up very much, especially in Africa. Tuberculosis, yes, there has been improvement. As I said, each disease brings its own challenges. We should not forget it. How has India fared? On track and beyond for poverty reduction. Slow off track for undernutrition reduction as it is defined. Child mortality moderately on track. Maternal mortality somewhat off track because of ambitious goals. Malaria, tuberculosis, AIDS. Tuberculosis and AIDS, reasonable. Malaria, not so good. We now move to something called as Sustainable Development Goals. And what does it give? From 8 goals, I will not keep you reading all this. They have moved on to 17 goals. So MDG has 8 goals, 21 targets, 60 indicators. Sustainable Development Goals, 17 goals and 169 targets. Time frame 15 years. Many medical people are terribly concerned. 4 out of MDG were health, and of that only 1 was achieved, and that too poverty, not directly health. Now in the SDG, only 1 out of the 21 goals is health. God, what is happening? But will this lead to dilution? This is the fear. But we should not fear. We have been doing well in health. There are small things that we ought to take care of. We must take heart by the fact that the first 3 are nutrition and health, and the health today talks really health, not disease control, but healthy lives and promoting well-being. They are doing the right transformation for us. We have major strengths, a network of primary, secondary, tertiary care institutions, excellent research and survey database on health, track record for well-conceptualized holistic interventions, a perceptive, rational, responsive, and extremely responsible population. It is on them that we lay our faith. System has weaknesses, inexplicable delays, very poor implementation, inequitable access, urban-rural, interstate, income group. Poorest and the most needy get the least care. We can build on our strengths. We can correct weaknesses. We should guard against complacency. If we do that, we can utilize the broader and more holistic interventions envisaged in SDG to substantially improve health status of our population. Thank you.
Thank you, ma'am. Thanks for your aspiring and thought-provoking talk. And I hope, and we can just see that how setting small targets helps us to achieve larger goals. So now there is a question answer. There's a request from all the delegates and participants. You can ask the question, just introduce yourself and then ask the question.
Related to the MDM policy, the midday meal policy, we ask students to go to a school for a quality education. But when we say that now you go for the school for getting a meal, school जाना है क्योंकि खाना मिलेगा. So and then the teacher are more focused on the food instead of the giving a quality education, and principal, teacher, or everybody is concerned with the food which is given to the child. It's not something which we make a mistake to put our MDM in a school set. What's your view on that?
MDM, an incentive to children who are out of school to come into school. And if you really look back, in 1995, what was given was 3 kilos of rice or wheat to a child who attended school for 80% of the days. And therefore, one of the major reasons for non-improvement of enrollment and more important retention was all the children are being sent to field to work, homes to work, and that economics is what is driving them out of school. So that was originally thought of as an economic incentive for children not to feel so desperately lost outside. Then there was, after 10 years of implementation of it, they said classroom hunger, inability of the child to concentrate is becoming a major problem. So give a hot food. So it evolved. Now teachers accepting to supervise the delivery of actual meal have no involvement in a cadre has been created for cooking, a cadre has been created for, and money is given specifically for cook, sweeper, helper, water supply, used, unused, misused, abused, they are part of the system. You belong to community medicine, you know that. Unless the community monitors and supervises and takes it as their program, these cannot be corrected from anywhere else. So it doesn't any longer take the teacher off the classroom. So, and if the child, I come from Delhi, not at all poverty ridden, but most mothers say thanks to Millennium, 6:30 बजे को बच्चे को स्कूल निकालना है, because we have a 2 tiers, morning school, evening school. खाना बना के उनको हाथ में देना बहुत दिक्कत है. ये प्रॉब्लम नहीं है, उधर जाके खाना खाएंगे. दोपहर में 2 बजे को अच्छा खाना मिलेगा. Mothers feel relieved. Khana is of a reasonable, I'm not saying 5-star quality, but they have a reasonably safe, reasonably varied menu, and most children eat it. Of course, aloo puri is the most favorite, and rajma chawal is the most neglected. The nutritionists won't agree. So it is no longer, it was a time when the teacher was supervising, but that is no longer the case. Are we using it to improve nutritional status? No, we are not, and I think that's what we do. School health and nutrition should use MTM as an opportunity to take it on. Programs evolve. Nothing is stationary at one level. If we keep improving it, we will get somewhere. Thank you. Yes.
Pediatric surgeon.
Yes.
And I don't know if it is right word. Your lecture was excellent covering the part of reduction of neonatal mortality, infant mortality. Now my experience of associated with pediatric surgery for more than 35 years and experience from the different medical colleges, 6% of the babies who they develop born with congenital malformations in India, and out of them 1 to 2% of them they need surgical intervention. I have discussed with my pediatrician colleagues and gynecologists, particularly I was the last part of my service was at NRS Medical College, which catered a huge number of pediatric surgical problems. There is significant mortality in neonatal surgery, even in the best centers in India. Even there are some congenital anomalies where the mortality is more than 40% even in USA or Australia. But when the neonatal mortality and infant mortality is calculated, I have asked a number of organizations, these dates are not taken into account. So are we getting proper picture when we give these mortality rates? Thank you, madam.
These congenital abnormalities, these that require surgical corrections, have an incidence rate of around 1 in 1000, 1 in 2000, 1 in 10,000. You see them, you treat them, you are appalled at the mortality. But they have happened to so few children. They are reflected.
Sustainable Development Goal. But one of the comments regarding this infant mortality rate is that we are able to reduce the infant mortality rate, but we are not able to reduce it further because of the low birth weight and the premature births, which we are not able to control. And I think in these goals we have not targeted about the adolescent. When the mother becomes pregnant or the lady becomes pregnant, then we start thinking about the mother and the baby. But if we can start earlier in the adolescent period, then we can drastically reduce even the low birth weight and also the preterm babies.
Thank you very much. You are getting me.